to you when you respond to the page that says your patient is short of breath. Now, like everything in medicine, there isn't a cookbook approach to things. You got to use your judgment. I would really love people to ask questions, and in particular to share wisdom from the older folks who've been doing this for a while. So what I'm going to cover, you got to call your patient short of breath, to think about your limited history, exam, and testing that you might be able to do, as well as some limited treatment options. The shortness of breath call in the hospital is not when you're going to think about starting pirfenidone for managing pulmonary fibrosis or initiated lung transplant workup. There's not a whole lot of things to consider, which is kind of nice because it makes it digestible. So has anybody received this equivalent page yet during the day or at night? Who has? Okay. All right. So I would hope you would ask yourself 3 questions when you get that page. After getting through the shock that you are in fact the doctor being asked to assess this. It's like, how bad is this shortness of breath? What's causing it? It's always easier to treat a problem if you know what that problem is, and what can you do about it? So how bad is it? You really are asking yourself the question, is this like a little shortness of breath between friends, or enough that the patient needs to be intubated? And really the only way you can answer that question is to go see the patient. But here are 4 scenarios. You might get the text page or the curator thing that says you have a 64-year-old lung transplant patient, satting 90%, high flow nasal, while on high flow nasal cannula oxygen, breathing 32 times a minute. Would you intubate that patient? Another patient, 83-year-old dementia, heart failure, lethargic, satting okay though. 22-year-old fulminant hepatic failure, encephalopathic, satting fine, but tachypnic. 74-year-old end-stage lung disease due to COPD, chronically hypercapnic, they're looking like a mess, DNR. Anybody want to say, like, I think I'd intubate A or C or D or B, or I wouldn't intubate anybody? Any one of these scenarios you feel confident saying, yep, that one I would, or that one I definitely would not? No, you wouldn't feel confident on any of these? Even the one that's already listed as DNR? It's America. At least I haven't checked my Twitter account in the last few minutes, but you're still allowed to change your mind. And so a patient, might have said in a theoretical sense, I don't want to be intubated, but when you're faced with that clear and present danger, sometimes people change their approach to things. So absolutely, no matter what's listed on your sign-out sheet, the only real way you can tell if somebody needs to be intubated or not is to go there. And so you need to go there. You need to go there now. I know that when I was an intern in the late 1800s, one of my co-interns got paged. We used to do this thing called overnight call. Probably heard of it. Every few nights he stayed over, and while on call, the nurse paged him saying your patient is short of breath, and he asked the nurse to put the bedside telephone to the patient's chest and have him take some deep breaths. That led to a conversation the next day with the program director. These patients you really have to go see. When you go see, let's move on to the second question then of like, how bad is the shortness of breath? And there is no app for determining which patients you're going to intubate. There's no ET tube equation. There's no mathematical model for it. It's you looking at a given patient and asking yourself the question, is this patient going to die if I don't intubate them or not? And it's the look, looking at them, do they look like they're going to die? Or I think there's a few categories of diseases which can give you the look. So a few years ago, when I asked one of our new interns, what his criteria was for intubating somebody, he confidently said VOPS, V-O-P-N-S. V for ventilatory problems, O for oxygenation problems, P for airway protection, and S for secretions. Those are categories of things that can give you the look, but there's still no one number for any of those categories that say intubate this patient and don't intubate that. So let's kind of break them apart. Ventilatory problems. That's the patient who is either not breathing at all. So I guess the respiratory rate is 0 would count as a reason for intubating, or they're breathing with so much work of breathing that you think they're not going to be able to sustain that. What am I trying to get at? There isn't any one respiratory rate above which you intubate. It's not like a respiratory rate of 32 allows you to go back to your call room and 33 you intubate. That's silly. There's no PCO2 level. You're all going to have patients whose ABG PCO2 is over 100, whom you're not going to intubate because it's a chronic stable condition. Meanwhile, most patients who are huffing and puffing like this have a low CO2. So there's no respiratory rate, there's no PCO2, and there's no pH that tells you intubate one patient or another. But those things like work of breathing and ventilatory demands may be the reason the patient looks like they need to be intubated. Next component, oxygenation. Does anybody have a O2, a PO2 or O2 sat that is a cutoff below which you would intubate a patient? Good, hopefully not. You know, the average person living in Nepal, not patient, but just a person, you know, walking around the mountains of Nepal, has a PO2 of 40. That's an O2 stat of 75%. And they don't all need to be intubated. You know, it's a chronic stable condition. So hypoxia can give you the look that says you need to intubate a patient, but there isn't a PO2 or an O2 stat that is your cutoff. And then airway protection, copious secretions, those are Gestalt things. So I'd probably belabored this point adequately, although I'm capable of continuing that process. Don't fool yourself into thinking when you go to see a patient and you're assessing them for whether they need to be intubated or not, that there's a mathematical equation or something you can Google that will answer that question. It's you using your judgment, looking at the patient saying, this person is going to die in the next 20 minutes if I don't intubate them, unless there's something you can do in the meantime to fix that problem. And I know you're all way far into your medical careers and have a lot of experience. There's nothing wrong with having somebody come look with you for a little bit, who's a little bit more senior as you're making these decisions. And I'd also throw out there that the next day when you explain why you decided to intubate the patient, your response is they look like they would die otherwise. That's a pretty ironclad defensible argument. Whereas if the patient gets tubed overnight and you have to explain, you know, why your judgment wasn't quite right, that's a little bit more challenging conversation. I'm not saying you should intubate everybody that coughs once, but have somebody come look at the patients with you for a bit. So I'm going to stop for a second. Questions on the idea of how you assess whether to intubate a patient and advice from any of the senior citizens in the front row or elsewhere.
Protection in an urgent scenario, all you have to do is get a tongue depressor and check their gag. But when you see this for the first time, you might be panicking and maybe a senior's not nearby or something. Just calmly say, okay, I need a tongue depressor and catch your breath, and then kind of assess in that way. If it were to be like a protection.
Yeah, that's amongst the hardest factors, and in fact. Dimitrov, asked me last year after this talk, like, are there any literature? Is there any literature or any guidelines for this? And it kind of sticking something in the back of the throat is as good as it gets. Okay, so first step, go see the patient, and you're making an assessment of whether this patient looks like they need to be intubated now or not. Now, if they, I guess I should carry this on a little bit further. What goes into the look? Sorry for being a little out of a sync. If the person can, complete the sentence that I'm completing right now without taking a breath, they probably don't need to be intubated. Whereas if every 2 words they have to take a breath, that's obviously important. Vital signs, call that for a reason. If somebody's in shock or has a BP of 300 over 200, a fever of, 112, so the vital signs are important factors to assess as well. And then the breathing pattern. Accessory muscles, you can feel them, you can see them, the things in the neck. If they're being activated with each breath, you'd worry that the patient's not going to be able to sustain that extra accessory work indefinitely. And if you can't fix the problem, they're going to tire out. There are 2 diaphragm-related things that get confusing. One of them is critically important. One of them doesn't matter at all. I happen to have underlined the critically important one. Would any of our interns like to tell me what thoraco-abdominal paradox means to you? I know I told these guys that it's a bad practice to just throw out there, does anybody, because nobody wants to answer. And so, Devin, you made the bad mistake. In a room when a person's talking and everybody's utterly just still, your eyes go to the one person who just took a bite, because like that, draws your attention there, and you just did that. So I'm giving you a moment to chew it and swallow it. But do you know what thoraco-abdominal paradox is? Okay, fantastic. So if you put a hand on your chest and a hand on your belly and you take a breath, what happens to the relative movement of those two hands under normal breathing circumstances? Do they move in the same direction, or do they go opposite directions? What is that? So a normal person, I'm talking about you right now, what would happen if you do here and here? Do they both go together, or do they go like that? Go ahead and put a hand there, and put a hand there, and take a normal breath. I think under normal circumstances, they both go together. All guys think you breathe by going like that, but that's only when you're posing, okay? If you put a hand on your chest, you could do it to one of our chiefs here, and a hand on their belly, and just have them take a normal, they both go like this. The mechanism is that we breathe primarily by activating our diaphragm, which pushes down on the abdomen, which pushes the belly out, and that draws the rib cage out with it. So normal people breathe like this. I was wrong. Matt asked me if I was going to strangle anybody, and I forgot I am going to. So if I strangled Matt right now, you would have a series of predictable observations. He would look distressed. Okay, the eyes, the sweating, the sternocleidomastoids, and eventually, with no air going in, like making maximum effort for a while, eventually the diaphragm would poop out. It would no longer be contracting. And yet your accessory muscles would still be working, pulling the chest up. But now the diaphragm, since it's not working, just gets pulled up into the chest, and you actually get a rocking motion of the chest and the abdomen. So people who've rounded with me know that I don't do thorough exams in the ICU. You know, I do my best to not touch patients because they have cooties. You know, we might call it MRSA today, but it's the same concept. But when patients are looking like they're about to die, I will throw caution to the wind. I will go into the room. I will touch them appropriately, putting my hand on the chest and the belly, and I'll feel for this rocking motion. And it's not that everybody who breathes like this with the back and forth has to be intubated at that moment. But if I see a patient who's complaining of acute shortness of breath and I observe this, that's a worrisome finding suggesting that the diaphragm has pooped out. And why did it poop out? Because of excessive work of breathing. And if you can't fix that quickly, they're probably going to die. So thoracoabdominal paradox, take it seriously. Now, another diaphragm finding is called Hoover's sign. It doesn't really matter, but a patient with emphysema who has a flat diaphragm, when that diaphragm contracts, the only thing it can do is pull in on the lower ribs. So Hoover's sign is inward motion of the lower ribs during inspiration. It means the diaphragm is functioning in a flat emphysema patient. So that doesn't really matter. The key is acute shortness of breath. If you feel this abdominal thoracoparadox, take it quite seriously. Pulsus paradoxus, I know nobody does this anymore, but I can't help but still talk about it. What's the setting in which you're hardwired from early in medical school that you attribute pulsus paradoxus to? Cardiac tamponade. It's not just the heart, okay? It's in the lungs too. So a normal, all of us, when we breathe, we create a little negative pressure in our thorax. Okay, you know, you breathe out, that creates a little negative pressure. That's why air flows in. If you measure somebody's blood pressure very carefully, you'll see that when they breathe in, the blood pressure in the arm goes down a tiny bit. So I'm going to ask one of our interns to say, if I asked you, go check your senior resident's pulsus paradoxus right now, what would you physically do? Ben, sorry. What would you do? Not always a good answer. Always a good. You're senior to your days in our program.
I would do them separately.
No.
Oh.
I said check Stephanie's pulsus paradoxus. You put a blood pressure cuff on and you do what?
I inflated with my diaphragm with my measure blood pressure.
Perfect. That's it. You measure the blood pressure. That's all you do. But you measure it and you pay attention. Normally, when we measure the blood pressure, we pump it up to 200 and let it drop to 60 in about 1 second and hope we can kind of estimate where the Korsakoff signs were. But if you let it down really slowly, you will find that in normal people, there'll be a blood pressure at which point you hear intermittently the heartbeats, like boom, boom, boom. And if you let the blood pressure cuff down lower, you now hear all the blood pressure beats, boom, 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 boom. Pulsus paradoxus is the difference between the first blood pressure at which you hear intermittent heartbeats and the lower blood pressure when you hear all the heartbeats. All of us have a pulsus paradoxus, and you're allowed to have a difference of up to 10 between the systolic pressure where you hear some of the beats and that at which you hear all of the beats. If I strangled Matt and repeated this process, when he breathes in, he would drop his intrathoracic pressure by 40 or 50 centimeters of water, which would drop the measured blood pressure out here by almost that same amount. So when, I know I'm never going to do it, but I still talk about it. So like a way of quantifying how bad somebody's work of breathing is in terms of how much intrathoracic pressure change are they requiring to generate to get air in and out. Pulsus paradoxus is a way of quantifying it. All right. Okay, air movement, if you don't hear any, that's bad. You know, if the patient's blue, that's bad. And if the patient says, I want you to take a tube and ran it down my throat, I would take that seriously. Very rarely do patients act out and say, I'd like you to intubate just to kind of ruin your evening as a cross-covering intern. So then, you know, those are things that go into your general assessment of looking at a patient. Does that patient need to be intubated or not? Again, there's no app for it. Have somebody look with you. Now, in terms of you've made a decision, this patient doesn't have to be intubated right now. You know, what can you do to fix the situation? Well, figuring out what's causing the problem will probably make it easier to fix it. The differential for shortness of breath in a hospitalized patient is probably endless, but some things that I think are reasonable to think about, we're going to run through. Aspiration. You know, old people aspirate. Sedated people aspirate. People lying flat on their back, especially with vomiting and things, aspirate. So aspiration has to be something to think about. Atelectasis and mucus plugging. I gotta admit that this is a concept that since I was your age, 5-6 years ago, I've struggled a little bit with, because I'd be called by the nurse that the patient's short of breath. I'd get there, they look fine. The nurse said they coughed up and it must have been a mucus plug. And I never saw the plug. Like I wanted to see the evidence of this plug that was causing all this problem. It happens though. You have a little bit of mucus, it blocks off an airway, causes you to be short of breath, and jiggles out and life goes on with it. Obviously, asthma, COPD, obviously heart failure, fluid overload. Effusions and pneumonia, like that always like confused me a little bit too. Those things don't happen instantly. Like why did the patient suddenly on your call night say that this effusion is causing acute shortness of breath? It happens. You know, the fluid builds up and it just reaches a tipping point that now it's causing physiologic and symptomatic consequences. Same thing for pneumonia. Pneumothorax, you know, obviously ventilated patients, but anybody admitted who has lungs, you know, there's a possibility that they could have a pneumothorax. You know, we put in lines, they have infection, they have COPD, all of those things can be problematic. I'm assuming one of you right now is having a PE because of your relatively immobilized status. So, you know, move your legs around a little bit. You know, any hospitalized patient, this is an issue. And sepsis, you know, back in the old days, like 2 years ago, we thought about sepsis when you first met the SIRS criteria and then blamed the SIRS criteria on infection. And one of the 4 SIRS criteria is a respiratory rate greater than 32. If you have to breathe a lot, that makes you feel short of breath. Now, the new, you know, sepsis, you know, screening thing is the Q-SOFA, you know, with the 3 things, lower blood pressure, altered mental status, and tachypnea. So the first manifestation of sepsis is often just a patient that is breathing rapidly, you know, metabolic acidosis, the effects of cytokines in the respiratory drive center, et cetera. Other things, these happen, but if it really any stage of your career, but especially now, your go-to answer for why somebody is suddenly short of breath on your call night is they're anxious, we need to have a conversation. Okay, panic disorders can certainly happen, but that's got to be like the last thing on your list to blame somebody's acute shortness of breath on. And how you figure it out, we have some limited tools. You know, you're going to look at the chart, ask a couple of questions. I'm going to briefly go through my approach to the pulmonary physical exam. So I think when you look at Bates or like Google the exam or probably wherever you went to medical school, somebody talked about the lung exam and made it ridiculously complicated. I'm a lung doctor, and this is just my approach. I think normal people have normal breath sounds. Okay, you all know what those are. And sometimes those normal sounds can be louder or softer than on average. So there's the normal sounds. If you do percussion, there's the normal percussion note in normal people. It can be hyper resonant or dull. And hopefully people are pretty confident at normal resonance versus hyper or dull. And then there can be extra sounds. And although you'll hear about 100 different adjectives applied to extra sounds, I think they fall into 3 categories. There's wheezing, okay? It's hard for me to whistle in front of people on demand. A long musical tone, so long and musical, because air is moving through a narrowed orifice, bronchospasm, wheezing, we know that. Crackles, short staccato. And if it's not either long and musical or short or staccato, we'll call it a bronchus. Okay, usually like mucus clears with coughing. I'm not really 100% sure what that is, but I don't use any other adjectives. If you want to sound fancy, you'll say rails instead of crackles, but crackles, wheezing, and if it's not clearly one of those 2, we'll just label it as other. So there are a small handful of disease presentations that I feel relatively confident that your exam can identify. Most of the rest require, an X-ray, a CT/PE scan, a history, but some exam things. We know this. I don't need to take your time. If somebody's having bronchospasm, you're going to hear wheezing. Somebody's got heart failure, fluid overload, you're going to hear crackles. Obviously, other things can give you crackles as well, like pulmonary fibrosis, but that would have been there earlier in the day, not just when you come to see the patient at night. For pneumonia, this is really confusing. I'm not going to belabor the point, but in a classic pneumonia, and let's face it, classic pneumonias aren't nearly as common as atypical pneumonias. But if somebody has a typical classic bronchopneumonia, on an X-ray, you see air bronchograms. And I know this isn't what's happening, but anthropomorphically, it seems to me that air bronchogram shoots the breath sound out to the lung edge where I can hear it more intensely. So it doesn't matter for pneumonia, over lobar pneumonia, you'd expect to hear increased intensity of breath sounds there compared to the rest of the lungs. You're going to make the diagnosis of pneumonia from your procalcitonin level, probably. Pneumothorax. Now, I want you to think about this. What type of pneumothorax worries us? Why? I.e., they're going to die. Okay. And how quickly do people die with a tension pneumothorax? Yeah. How do you treat a tension pneumo that's going to kill them within minutes? Meaning taking a needle and sticking it into the chest. They're going to die within minutes, far too quickly for you to send them downstairs for an X-ray or go get the ultrasound machine. It's unlikely it's going to be you, but it's going to be somebody in this room that at some point this year is going to grab a needle to decompress a tension pneumo solely because of your exam. So, you're not going to be able to Google quickly and watch a YouTube video on how do you tell if somebody has a tension pneumo on physical exam. Think about what you'd expect. So you would like shock. That's the definition of a tension pneumo. It's not pushing the mediastinum or expanding the chest. It's hypotension, tension pneumothorax with physical exam findings to support a pneumothorax being the cause. So hyperresonance and decreased breath sounds. So, you may walk in a room, they're in shock. Could this be a tension pneumo? Tap and listen. And if you have these findings, it's enough to grab a needle. We'll talk about the technique in a minute, stick it into the patient, catch your breath, and then go on with the rest of the day. If the patient didn't have a pneumo, well, they may now have a pneumo, but with the catheter in place, they're not going to have a tension pneumo. Okay. So if somebody's, the reason we're doing this is they're in shock, i.e. dying, you're not likely going to make the situation a whole lot worse. So I just really want you to think about this. In terms of atelectasis and effusion, you're never going to 100% worry about your exam for making the diagnosis, but this is what you'd expect. Very, very similar, atelectasis and effusions, there'll be dull and a lack of breath sounds. You're going to use an X-ray and ultrasound to sort these things out. Technically on exam, when it's atelectasis, that hemithorax will be smaller than the other. Maybe the trachea would be sucked into that side, and then the opposite with an effusion. But those things are kind of hard to assess at the bedside. And this is my extremely limited approach to the physical exam in clinic as well as at the bedside. Comments from old folks of physical exam findings you have found useful? People still do that occasionally, right? Okay. Along with the ultrasound, along with focus. Okay. So, our differential, you're going to think about getting an X-ray. This X-ray, I think, looks normal. I hope so. It was mine. You know, on our differential diagnosis here, what things could this person still have as a cause of shortness of breath, despite the clear X-ray? PE. And I got to tell you how many times through the years I've had a conversation with someone saying, well, it can't be a PE because the X-ray is clear. Well, no, it's when the X-ray is clear that should exactly make you think of a PE. So PE, you know, but also sepsis, bronchospasm. You know, maybe the patient in classic bronchospasm is hyperinflated with flat diaphragms, but, you know, clear lungs, for sure, thinking about bronchospasm, PE, acidosis, sepsis. Terrible rendition. It's not the black hemithorax on the right that's the problem, but this is trying to illustrate in the patient's left upper lobe is it's all white except for air within the bronchi. So those are air bronchograms suggestive of a broncholobar pneumonia in that area. What do you think the problem here is? Whiteout on the patient's right side caused by? What is that? Masses at atelectasis. What's the other alternative? Mucus plug or an effusion. And I think most of our eyes or most of us like tend to think about infusions because if it's an infusion, you can grab a thoracentesis kit, do a procedure, make somebody feel better. But this is not an effusion. And they look the same in terms of whiteout, but the difference is that in an effusion, when we add fluid to this hemithorax, it ought to push the trachea to the other side. Whereas in complete atelectasis, it draws the trachea into that side. So nowadays, you know, you're going to grab your ultrasound and sort this out. But whiteout is one of three things. It's either complete atelectasis, like here, for whatever reason, a massive effusion for whatever reason, or you could have whiteout where there's pneumonia throughout the entire hemithorax, but we ought to be seeing the air bronchograms that you see in a classic pneumonia. Thoughts? What might this represent? Yeah, an infusion, you know, this person has a heart, but on top of that also has some sort of, you know, device in, you know, maybe they have heart failure, who knows along that, but, you know, a reasonable case for heart failure with an effusion on the right. Any thoughts? Terrible picture and all the lights on, can't see anything. So I'm just going to say if this were visible, you'd be able to tell that there's a lack of lung markings in the patient's right, the patient's left hemithorax on the right side of our screen here. Looking for pneumos is hard. So that's the point behind this. Identifying pneumothoraces can be very challenging. So have somebody look with you. You know, there's a senior resident, there's an in-house pulmonary fellow or attending. You know, there are radiologists in-house. You'll grab an ultrasound to sort it out. But pneumothoraces, I think the point behind this is that they can be challenging. So if you're looking at a film to look for a pneumothorax, accept the challenge ahead of time. And if you're not sure, have somebody else look at it with you. I can't help but, you know, old anecdote. Have any of you seen actual x-rays that you put into a view board? Like this, you guys have seen those, right? Like in movies or something. So in the old days, when we would look at an x-ray to identify a pneumothorax, the entire team would stand at the usual and customary distance away from the view box. And then the oldest person in the group, which for most of the last 100 years has been me, would move away and then would move closer. And then somebody would pull the bottom of the film away from the view box to look at the film kind of tangentially. Does anybody know why we would be doing that when we're looking for a pneumothorax, pull the film out and look at it tangentially? It was looking for the smudge marks caused by the radiologist's fingers when they were pointing out the abnormality. So telling pneumothoraces is hard. What was done between this patient's first film on our left and the second film on the right? Any ideas? That's the answer. So nothing was done between these two films, and it's simply an opportunity to talk about which x-ray do you order? Portable or a PA and lateral? PA and lateral gives you far better detail. I mean, look at the difference between these images just by the different quality of a portable film versus a PA and lateral. PA and lateral, it's high quality. You can tell so much more detail. What's the biggest negative of a PA and lateral? the patient has to go downstairs to radiology. And if you're seeing the patient for acute shortness of breath, you got to make sure they're stable enough to go downstairs for that process. Now, the negative of the portable is that it's almost like taking out your iPhone and taking a picture of their chest in terms of the quality of detail. So which you order depends, a judgment call. If it's just kind of mild shortness of breath, send them downstairs. If they're unstable, do not do that. All right, so diagnostic studies, we commented upon a chest x-ray, what type, in terms of a pulse ox versus an ABG. Again, this is a judgment call. If you put a pulse oximeter on somebody and there's a good waveform and the measured O2 is low, I think you have your answer. The low oxygen is why they are short of breath. Still doesn't tell you whether to intubate or not, that's the look, but you'd say, wow, they're short of breath because they're hypoxic. Let me figure out why they're hypoxic. But if you put a pulse ox on and the waveform is garbage, ignore the number. So many times I've seen situations where there's a number on the screen saying, 70 or 100, but it's virtually a flat line to the pulse oximeter tracing. If the tracing is no good, just ignore those data. And if the tracing is good and the measured value, the reported value is okay, then you need to get an ABG, because there's nothing allows me to look inside Nick right now and tell what his PCO2 and pH are. So whether you're going to get an ABG or an O2 depends on the circumstance. My final comment on this is I've seen occasions through the year where a really well-intentioned intern has spent hours at the bedside trying to get the ABG. And that's not going to answer the question of intubate or not. Maybe your time could be better spent in other ways, trying to help the patient get better. So, send the student to get the ABG, keep them occupied for a while, and you can move on to figuring out what's wrong with the patient. So comments from old folks like, when do you get an ABG in patients? It's never a bad idea to say, I'm going to try to get one. But, what's your threshold for that? Chris, you doing everybody or? Yeah, when you're like anything, any test, you get it when you're confused. You don't know the answer to things. A good pulse ox with a good tracing, you can trust the number. Anything else, you can't trust the number on oxygen, and nothing on exam or non-invasively tells you a pH or a PCO2. Matt, were you about to say something?
Yeah, the best $20 I ever spent was buying my own pulse ox on Amazon. It saved a couple MICU transfers for rapid responses where it was just a bad pulse ox. They can be a little more reliable than what's on the floor. It's super nice to walk into a room, put it on, say everything's fine, and when it's just a hospital pulse ox thing, it's a
that was
really good investment.
$20 better spent than the $20 spent on the engagement ring. Another comment on that, you'll see that the things on the forehead, yeah, I just don't know about that. And then like a side note that I think has been fascinating over the last year, that one of our former residents, who's now a pulmonary fellow at Colorado, had an editorial in one of the major pulmonary journals this year highlighting that in dark-skinned individuals, normal pulse ox values often are not accurate and the patients can still be hypoxic, and that we've known about this for many, many years and nobody's done anything about it. Like, side note to the side, like an example of label it institutional racism, whatever, just inappropriate approach to this in our medical profession. Also interesting is our graduate did this most recent editorial, but his main literature that he cited was from 15 years earlier from a graduate of Sturch's medical school who had done the original research highlighting this, Michael Schoding. I don't like him as much though, because he went to Michigan. Other comments about the ABG? Were you about to say something? Code blue?
Go blue.
Go blue. Okay, all right. Okay, bronchodilators. Now, this is like also a side note before diving into this. You get the call. You're probably a little bit anxious in general. You're not sure what you're going to see when you get into that room. The nurse is waiting for you to do something. And with rare exceptions, saying, well, get the vitals, get a pulse ox, always do those things. But with rare exception, it's okay to say, put on a face mask and start a breathing treatment. We'll go through the exceptions when those would be bad ideas, but that's a reasonable thing to start some stuff that may or may not help the patient, but at least makes the nurse think you're a doctor. That is kind of good for the general relationship when you arrive. So when is a bronchodilator going to be helpful is when the patient is bronchodilator openic. Okay. If the patient is having a PE, a neb isn't going to help. You know, if it's sepsis, the neb isn't going to help. If they have bronchospasm, the neb is going to help. It's rarely going to hurt though. But what are the main side effects of a breathing treatment? And when you say breathing treatment, it's a mixture of albuterol and ipratropium. But what's a circumstance where you'd worry about giving somebody? What is that? Tachycardia. So now this is an issue because if I were strangling that, he'd be tachypnic and tachycardic from that. And if the bronchodilator relieves the bronchospasm, then the bronchodilator is going to help the tachycardia. But if your sign-out sheet says patient was admitted for malignant ventricular tachycardia, maybe I would avoid the beta agonist under those circumstances. And then you also know from Dr. Polakowski that in treating hyperkalemia, you can use the beta agonist to drop the K, maybe half a milliequivalent. So somebody already has a potassium of 2, you might not want to give them the bronchodilator on top of it. So points behind the nebs, reasonable thing to start unless you have the sign out of hypokalemia or severe tachycardia issues, but they're also only going to help if the problem was in fact related to bronchospasm, COPD, et cetera. Comments about the nebs? Also related to the oxygen, we'll come back to in a moment. Guess we'll do that right now. So if I strangled Matt right now, and he clearly is dying of shortness of breath, he'd probably maintain a normal oxygenation for a long, long time. Anybody here ever try to hold your breath long enough to drop your pulse oximeter value? I think he does all the time. I mean, that's why he ordered the $20 pulse ox. I mean, it's hard to do. I challenge you, grab a pulse ox and try to hold your breath long enough to desaturate. It's really hard. Most people have an intense drive to breathe, and you're not going to be able to do that long enough to drop your oxygenation. So a normal O2 doesn't preclude reasons that the patient is short of breath and needs to be intubated. But the more important thing is once you're saturating adequately, giving more oxygen isn't going to help. So don't fool yourself that by giving a distressed patient a face mask is going to help them if they weren't hypoxic to begin with. It's rarely going to hurt them. We all, worry about giving somebody too much oxygen to blunt their drive to breathe. Yes, it can happen, but it's rare. And unless your sign-out sheet says, CO2 retaining COPD patient prone to blunting their drive to breathe, I'd still be encouraging you to give them oxygen, like while you're walking to the room. You're going to be there in 2 to 3 minutes. I think it's something to think about, but not make you afraid of giving oxygen to. So points behind the oxygen. If somebody's PO2 is okay, more oxygen isn't going to help. It's probably not going to hurt unless you have one of those rare patients who really stops breathing. Comments? Which device you're going to use, you have some options, and it's not like you have to start low and go high or vice versa. It's your judgment call. The oxygen coming from the wall is always 100% FiO2, but for each liter per minute going by your nose, that increases the delivered FiO2 by about 3%. So right now we're all breathing 21%. At least that was the case before this room heated up over the last 30 minutes. So if you put somebody on 2 liters per minute, you'd now say they're probably getting 27% FiO2, the 21 plus 3 for each liter. Not a big deal. Simple face mask, a little variable, non-rebreather, you can get up to 100%. When the patient breathes in, theoretically, their next tidal volume is entirely from the bag of pure oxygen. And a side note, once in a while, an enthusiastic intern will say, look at these little flaps on the mask. Maybe I should duct tape those to prevent even more room air getting mixed in with it. There's very few circumstances where duct tape is useful in clinical medicine. This is not one of those. So you can get up to 100% FiO2 through a non-rebreather mask. And by the way, you're never going to choose between a rebreather and a non-rebreather. There are no rebreathers in internal medicine. There are rebreathers in the ER if a patient's having a panic attack, so they don't lose all their CO2 and vasoconstrict and pass out. And then in the OR, they have a rebreather so that the anesthetic they give to the patient goes back into the patient instead of being released into the operative field, which would be entertaining, but perhaps problematic. A Venturi mask, I've never in my life ordered one. But if a respiratory therapist comes up to you and says, I'd recommend one, I'd say, okay, let's use it. What is it? It's a simple face mask fitted with one of several color-coded Venturi valves. And just the theory behind them is that when you put them on a Venturi mask of 35%, they will get a more precisely determined 35%, as opposed to putting them on a face mask, where you're not 100% sure what they're going to get. So if a respiratory therapist says they think it would be helpful, run with it, but I've never found the reason to use it. And then thank goodness somebody invented high flow nasocannula oxygen, Optiflow, Vapotherm. It's a super high flow rate of humidified and heated air that makes it tolerated. And in our ICU here, I bet every single day there's at least one patient who without Optiflow would have needed to be intubated. So, which do you use? It's up to you. Somebody's acutely short of breath and their SAT is super low. I wouldn't start with a nasal cannula and work up. I would just get a non-rebreather mask. Whereas if it's a little milder shortness of breath and the oxygen isn't a big deal, maybe a nasal cannula. People who've been doing this in the trenches more recently than I. Chris, how do you pick which oxygen to put on somebody? Just depends. Yeah. Okay. All right. Okay, then we only have a couple other things we're going to run through. Talk about BiPAP, we're going to talk about Heliox, and first we're going to run through the pneumothorax emergent decompression process. Remember, it probably won't be you, but it'll be somebody, and you're going to encounter the patient with the tension pneumo where you need to treat it long before you can call your senior to get them down there, or YouTube video the process. So the answer of how to do this is pretty simple. I guess that's the next slide. Sorry. So non-tension pneumos, just a pneumo in general, if it's a small pneumo, and we really define small by the hemodynamic impact and the symptom impact rather than the size on the X-ray. But if it's kind of an incidentally identified pneumothorax, you don't have to do anything about it, but we will typically give them supplemental O2 because of a theory that it'll speed the resolution of the pneumo. Side note, probably doesn't work, but if the patient's hospitalized with a pneumo, putting them on oxygen is fine. If it's more significant, based upon patient symptoms, you're going to put in a chest tube. It won't be you. Call the pulmonary fellow. If it's smaller, call the CV surgeon. If it's bigger, they'll decide whether to put in a small bore chest tube or a large bore chest tube. And then let's go through the emergency decompression. Okay, so let's think about what you're going to do. So it's grabbing an alcohol wipe, a couple squishes over the spot you're going to put it in, which is mid-clavicular line, second intercostal space. You grab the angiocath, just the IV catheter. You put it over the rib, aiming at the patient's soul, just like directly into the middle of their chest, and just push it in, paying a little attention. It makes you feel better if you feel a little pop as you go through the parietal pleura to say, hey, okay, now I'm in the pneumothorax space, and listen for a little of air escaping. First time I did this, I was disappointed because I expected with the tension pneumo, if I put the needle in, as soon as I got into pleural space, the patient would fly around the room because of all the air escaping. And it's just like a little, and it's gone. So pay attention for that. And once you're in the pleural space, advance the plastic catheter over it, pull out the needle, chill out, and call CV surgeon to put in a formal chest tube. Who else in the room here has ever done this? Chris, I thought you were signed off on this. Not yet. Okay. All right. So think about it. Shock with hyperresonance and no breath sounds, grabbing the angiocath, alcohol wipe directly in, pass the plastic catheter in, pull the needle out, and call CV surgery. A couple of chest tube devices that I think are worth commenting upon. If you go to see a patient and they have something odd sticking out of them, it's worth asking your question, could that be part of the problem? So chest tubes can be attached to either if it's a small bore chest tube, a thing called a Heimlich valve, or if it's a big bore chest tube, attached to what's called a pneumovac. And I just want to describe them to you. So if there's a small bore chest tube, you can attach it to this plastic thing called a Heimlich valve. So there's a plastic tube inside of which is a rubber tube. So about the size of a kazoo. And the rubber tube is circular at one end and tapers to a narrow slit at the other, such that when the patient exhales, it could push air into the circular end of the rubber tube and go out the other end. When the patient breathes in, it closes. So it's a one-way valve allowing air to escape. So if I see a patient with one of these sticking out of them who's saying they're short of breath, yeah, I think, well, maybe this is part of the problem. And I'd want to look at it to see if the rubber tube is titling, like moving as the patient's breathing. If it's not moving as the patient breathes, I'd worry that it's not actually connected to inside the chest. And I'm going to call the person who put it in to do like the full evaluation, but I would look at the catheter to see if it's obviously vent coming out of the chest. Did somebody clamp it? And you could simply unclamp it and maybe air will release and the patient would feel better. So any old folks, any experience with these Heimlich valves? They're a nice adjunct. Patients sometimes go home with them and they come in the next day for an x-ray. But I look at them to see, is the rubber thing titling? And if it isn't, then I want to look at the tubing exiting the patient's chest to see if it's kinked, clogged, or if somebody has turned the one-way valve stopcock, and that's the reason behind it. Similarly so I look for titling. Okay, with the chest tube, these Pneumothorax have 3 separate containers built into the one device. The first container is to catch the drippings from the pleural space. The second chamber is our water seal, which regulates, it's a one-way valve, effectively allowing air to leave the pneumothorax space but not get sucked back in. And then a third container, which regulates the amount of pressure seen by the chest. This is what it looks like all at one. On the right is where the fluid accumulates. The upper left is where there's a valve to say what the pressure is being applied to the patient. But this is the part I want you to look at. In the lower left, there's a little window in which will be 2 centimeters of blue colored fluid. Somewhere along the way, that became a constitutional amendment that it needs to be colored blue. There's some blue fluid in there. And if the patient has an ongoing pneumothorax and air is leaving the lungs into the pleural space and leaving through the chest tube, you will see bubbling in this chamber. So if there's bubbling, it means they have an ongoing pneumothorax. Doesn't necessarily answer your question what to do next, but it's an important fact to communicate to the CV surgeon who put it in. And the second is to look to see if when the patient breathes, fluid gets sucked up this column and goes back down. I strangled Matt, he creates negative intrathoracic pressure and then positive. And so this fluid should go up and down. If there's no fluid titling, then I worry that it's not connected to the chest, just like with the Heimlich valve. I would look to see, is it clamped, is it kinked, or is it clogged? So I know I am 2 or 3 steps beyond any utility for this afternoon on this. But when somebody has something sticking out of their chest and they're complaining of shortness of breath, I would have some consideration that maybe that's part of the problem. And at a minimum, call whoever put it in to ask them come assess the patient. They will look for titling and bubbling, and just wanted you to know what that means. 2 more things. CPAP, BiPAP, you're allowed to use this in any circumstance where you think it's appropriate. Studies have shown that if somebody meets criteria, now we already said meeting criteria for intubation is kind of a made up thing. There's no app for that, but like experts reviewing data saying that patient should have been intubated now. If instead of intubating, you fiddle with BiPAP, they have a higher mortality rate. So if somebody needs to be intubated, don't fiddle with BiPAP. But if somebody's like short of breath and not quite at the point of needing to be intubated, BiPAP is a reasonable thing. The terminology is confusing and you'll never be asked to choose between CPAP or BiPAP. The terminology though, I just want to go through in 1 minute. CPAP is a continuous amount of positive airway pressure that works like PEEP does on a ventilator. So it's good like PEEP for pulmonary edema. BiPAP is bi-level. So you set 2 pressures, one of which is an inspiratory pressure. So when the patient breathes in, they get extra pressure, like pressure support on the vent. And then when they exhale to the expiratory pressure, EPAP, which is like PEEP and CPAP. So very confusing. You're not going to choose. The respiratory therapist is going to do whatever they think is right. Your job is to think about the settings. Would this patient potentially benefit from a trial of BiPAP? And again, you're allowed to try it in any circumstance, but these are the settings that have been studied in the literature with data to say it's likely to be beneficial. So a COPD exacerbation that isn't so bad they need to be intubated, BiPAP may help with the work of breathing long enough for your bronchodilators, steroids, and antibiotics to kick in. Pulmonary edema. While you're diuresing them, the BiPAP emphasizing the PEEP part might help address the hypoxia rather than having to intubate the patient. In the bone marrow unit, it's simply a fact that around the world, intubated bone marrow patients die most of the time. It's not that the intubation is what kills them, but because that's the case, we have a practice of using BiPAP in those patients, hoping it buys time for antibiotics and family decision-making. And then finally, neuromuscular disease. You have progressive ALS, it can reach a point where they need to be intubated. You might be able to use BiPAP to buy some time for the patient to think about that and make their plans. Now, I've said it a few times, you're allowed to use BiPAP in any other setting, but don't have confidence that it's going to work in other settings. These are the areas in which it's been studied. The therapist is going to do what they want to do, but you have to type something in the computer. So we usually use 10/5 as our BiPAP settings, and then the therapist will adjust those values to the goal of the patient looking more comfortable. And then in terms of how long you can tolerate BiPAP, this thing on your face here, 12 to 24 hours. If the patient has a disease process underlying that you think is going to take longer than that, I wouldn't fiddle with it. And then finally, Heliox. Anybody in the room use Heliox ever? I know I talked about it with our ICU team a month ago. The specific setting to use it is upper airway obstruction. So what is it? It's replacing the nitro-ox we are breathing now, meaning nitrogen and oxygen, with Heliox. So we still need the oxygen, but you replace the nitrogen with helium. And through complicated mathematical questions or equations, it ends up that if you replace nitrogen with helium, it's easier to breathe the oxygen through a narrowed airway. So angioedema, you see 1 or 2 every day getting admitted to the unit. They come into the ER because of a, ACE inhibitor or shellfish allergy. They get evaluated in the ED by ENT to make sure they don't have critical airway narrowing. They never have critical airway narrowing, but they get admitted to your ICU team to be observed. And they're going to be better in 12 to 24 hours. You'd hate to intubate a patient like that when they're going to get better shortly, and you could buy time by using Heliox. And if you're going to think about Heliox, you just ask the respiratory therapist to bring up Heliox, and they'll take it from there. So upper airway obstruction. And then finally, if your patient does need to be intubated, you're the floor team, you're going to send it off to the unit, but you're in charge of the patient until that happens. Monday, we're going to talk about vents in more detail, but to have a backup set of typical ventilator settings written down that you could apply to most circumstances, these are what I would recommend. Comments from anybody about approach to dyspnea? All right. Hope everybody has a good Friday and weekend. Good day, folks.